Hey guys, my name is Mike Loria. I'm a former pararescueman in the United States Air Force, former flight paramedic for the Dartmouth Hitchcock Advanced Response Team, and currently I'm an emergency medicine resident at the University of New Mexico with a particular interest in performance in stressful situations and cognitive science. This presentation is on emergency reflex action drills and was presented at the National Critical Care Transport Medicine Conference. To begin, I have no disclosures or disclaimers. No one's paying me any money to talk about this or present any product. If I talk about anything, it's because I think that product or that something is good or of value. So I started out thinking about this whole concept several years ago, about 6 or 7 years ago. I was talking with a friend about a situation in the civilian air medical transport arena where a pilot and flight crew were on their way to pick up a patient. This was a very highly trained, highly experienced flight crew pilot, and their equipment was very good as well. They had a very nice aircraft, twin engine, equipped with IFR capabilities, and at least according to the initial weather reports, everything should be within safe weather limitations. However, en route to pick up the patient, they encountered very significant clouds and weather that obscured their vision. They basically flew into the clouds, and the pilot immediately responded by leveling out the aircraft, pulling power, and climbing to approximately 7,000 feet, and calling the regional air traffic control center and letting them know that he was currently in instrument meteorological flight conditions and had arrived in that situation inadvertently. So he immediately pulled power, climbed up, wings level, and called out saying, XYZ Center, this is November 123 Yankee X-ray, currently inadvertent IMC at 7,000 feet, heading 123, and requesting IFR approach to local airport ABC. It was pretty interesting hearing the description of the events because the gentleman I was talking to had said that otherwise this is a very serious condition, and theoretically could have been avoided, but the team ended up in a situation where they were in, and a otherwise very serious emergency that could have resulted in loss of life in aircraft became a non-issue because the pilot was very well trained and immediately executed a procedure that put them in a very safe situation and allowed them to navigate safely to an airport. It really made me think about how people had trained to do very automatic reflexive behaviors. And I actually thought about a situation that I had run into in the military. A friend of mine was actually engaging a threat, and as he initiated or began to return fire, as soon as he pulled the trigger, he heard a very concerning click as opposed to a bang, meaning that something had happened and the weapon had malfunctioned. But this also became a non-issue because of his very rigorous training. He basically slapped the bottom of the magazine, making sure it was seated appropriately, racked the weapon system, removing what was a dud round, and immediately went back on target and was able to return fire. It was because of his training and his reflexive action that what otherwise could have been a very serious situation turned into a small troubleshooting situation that only took a few seconds to fix. When I started to think about it even more, I began to realize that there are certain very time-sensitive critical situations in medicine that we run into, especially in emergency medicine, critical care, other acute care specialties like anesthesia and surgery, where time is of the essence. There's not a lot of room to have a discussion or a caucus or run a checklist, and things need to be done very, very quickly. And so that's what this presentation is about, how I think we can apply some of this training from other high-risk areas to develop tools and techniques that will help us in very time-sensitive critical situations. And what I want to talk about is start talking about the effects of stress on how we think, human factors fixes from other domains, so how other high-risk occupations have addressed this, and finally talk about something I call ERADs, or Emergency Reflex Action Drills, and how we can build these fixed motor responses to basically respond very quickly and efficiently to medical emergencies. So it all begins with this stress. As we're going around or as we run into situations in emergency medicine, anesthesia, surgery, critical care, etc., we come across situations that take us by surprise and cause us to be stressed out. Our heart rate goes up and we experience other changes, in particular, fundamental changes in the neurochemistry of our brain and how we think and how we act. And the unfortunate part is these sequelae can affect our performance and affect how we provide emergency care. And these changes can, in essence, be pathological. And some of the changes we see include things like tunnel vision. When we get stressed out, our brains actually get tunnel vision. And in the human factors world, we call this increased selectivity, but we tend to become hyper-focused on certain things. We also tend to see degradations in our sensory capacities. In fact, in certain studies looking at military and law enforcement personnel and lethal engagements, people have experienced rates of up to about 68% of auditory exclusion. In other words, people have been yelling important pieces of information at these individuals or telling them critical facts, and they just didn't hear it. They were so stressed out that they just did not hear it or did not process that information. Other things we see is that normally our brain is able to triage information very appropriately and very well. So we can figure out what needs to be done now, what needs to be done later, what's the most serious medical condition that we have to address now, and what may be able to be left till later. And that starts to break down as well. That starts to break down fundamentally. In fact, combine this with other effects like the tunnel vision, and we see very salient symptoms of this ability to triage breaking down. So, for example, the patient, a patient with traumatic injuries comes into the emergency department and they have a very, very eye-grabbing, compound, open lower extremity fracture. However, the patient's also having some difficulty breathing. Now, just about everybody would be able to recognize that ABCs come first and we need to address the breathing problem. But what we see in real life is over and over again very smart people being sucked into these very distracting injuries and ignoring the things that are probably most important to the patient. And it has nothing to do with their level of intelligence at all. It just has to do with the effect of the stress on their brain. We see other things too, like for example, problems with memory or remembering things. Our working memory is significantly compromised when we get stressed out. I'm sure everybody has experienced that situation in real life or even in educational situations where you're asked a question and you know the answer so well. You've done this procedure 1,000 times. You've administered a medication 1,000 times, and someone asks you a question about it, and your mind goes blank. And you know deep down in the recesses of your brain that information is there, but you can't seem to draw it out. This is a fundamental problem, and it is very, very common, and again, has nothing to do with intelligence. Those effects of stress on your brain are causing problems with your working memory, and you just can't remember the information. You can also see problems with novel processing of information and problem solving as well, also related to issues with working memory. Other things we see, increased ability to get distracted. So our brain sort of hops around and gets tunnel visioned or focused on different things, but you're very easily distracted. So you might be in the middle of doing something very important and someone asks you a very simple, very benign, not so important question, and all of a sudden you stop what you're doing and engage in a conversation. Very common, and we know that we really should be finishing the critical procedure or addressing the critical information, but our brain just gets easily distracted by people asking them questions or other things going on around as other sensory stimuli. Likewise, we see an effect called psychomotor perseveration. It's a very interesting effect, and it's commonly called the broken record effect. And what we see is that when people get stressed out, their brain tends to default to what it already knows. Again, an issue with novel processing and problem solving. So that's why we see sometimes people doing the same thing over and over again, getting the same result, which is generally not great. But have you ever seen someone trying to intubate a patient? and they're just sort of moving the laryngoscope around in their mouth, and you're asking them, well, what do you see? And you start to see that look of confusion on their face as they struggle to find the vocal cords and the glottic opening. And they're just sort of moving around the laryngoscope in the patient's mouth. This is demonstrating behavior that's not necessarily goal directed. They're just doing the same thing over and over again because that's all they know how to do. And their brain is failing to stop and pause and think about the situation appropriately and try and solve the problem. So, all suboptimal effects of stress on the brain. Now, over time, I'm sure people who are very experienced have developed little tools and tricks, from the way they set up their equipment to the way they go about executing certain procedures, that has allowed them to function better in stressful environments. And in the human factors world, we call this strategic adaptation. And we see it in various environments, and there are some very benign, very daily examples of this. For example, how many of you have actually, when you leave the house to go to work or you leave the house to go do something, you check and make sure you have your phone, your wallet, your keys, your kids, whatever it is. You have like this little thing that you go through in your brain to make sure that you've got everything, or your little mental checklist before you go. Or better yet, how many of you keep your keys, wallet, other important stuff in one particular place in the house, perhaps hanging on a hook or by the door so that you don't forget it? These are all behavioral adaptations to get through your normal day and not forget things. Well, we actually specifically teach people some of these skills and access that same cognitive architecture by teaching people in emergency situations structured responses in time critical circumstances. So we actually teach strategic adaptation, and there are a number of examples of these. For example, in the world of mountaineering, if you're sliding off the side of a mountain, we teach people to self-arrest using various techniques, and we essentially drill it into them, because we know when you're sliding in the snow off the side of a mountain, it's not a very good time to try and stop and think and take a few seconds and figure out exactly how long you have till you plummet to your death and then come up with a solution to the problem. No, we actually teach people to immediately execute a series of steps to arrest themselves, stop themselves from sliding before they die. And then once they stop, okay, you can take a couple seconds, you can figure out what went wrong, and you can come up with a solution to the problem. But the key is to stop sliding. Likewise, in the world of diving, in particular, in the combat dive school, they teach you a series of steps to go through when you lose your air source. So the very first thing you do is go ahead and reach back, find where your air source is connected to your tanks, trace that all the way out, retrieve your air source, bring it back to your mouth, and then cycle your tanks to make sure that they're both on, cycle your reserve tanks to make sure they're on, and go ahead and you actually execute a series of other steps as well. But those initial steps are critical, because you don't have a lot of time when you're swimming along and you lose your air source 20, 40, 60 feet underneath the surface of the air, of the water, that is. So you execute this specific skill set immediately, and then you go about troubleshooting the problem in terms of what happened, why did you lose your air source, what's going on around you. We also teach very similar things in tactical situations. In the tactical environment, if you're patrolling or moving toward a target and the enemy engages you or ambushes you, we execute very, very specific drills to return fire, bound back, and that is actually really, really critical, because when there's bullets hitting the ground around you, you don't have a time or the cognitive bandwidth to sit there and have a conversation about what's happening, who's shooting at you, how many people are there, etc., etc. So you execute this immediate task skill to stay alive, bound back to a position of security, and then you regroup and discuss what's going on. Emergency reflex action drills are designed to access the same cognitive framework, to address the same time-sensitive critical situations, and are based on some of the evidence from other high-risk occupations to help us perform in these time-critical situations. And basically what it comes down to is developing fixed action patterns in various circumstances that are evidence-based. And in this case, I would like to present to you an example in airway management. Now, a couple things before we get started and I go through the example. First, Some of my colleagues in the world of academia would shudder at the thought of reflexively responding to something without thinking about it. And they would propose that as trained clinicians, doctors, or experienced nurses, paramedics, respiratory therapists, whatever, that our job is to think about these problems carefully, analyze things, and for the most part, that's true. But the evidence in other high risk occupations would clearly demonstrate that this is not the case. And in many cases, coming up with simple solutions that your brain can easily manage when it's stressed out in emergencies are actually more effective. Now, I would hasten to add that what I'm not advocating for not thinking. I'm saying we should actually do the thinking in advance, come up with evidence-based techniques, and simplify those down to a series of steps that you can execute when you're stressed out. So it's not about not thinking, it's about knowing how to think and about understanding when to do the thinking and analysis. Number two, these are things that are not amenable to checklists, right? If we start getting shot at in the middle of a road in Iraq, we don't sit there and have we're about to get shot up checklist. Okay, let's see. Let's go through this. So, so getting shot at. So take cover, get down. Okay, cry and pray to God that we don't die. Okay, check. And then curl up in the ground, the fetal position, and kill you and pee yourself. Okay, so yes, done. Urinating on myself right now. Right. So that's not a checklist. That is not a time to execute a checklist. Likewise, there are certain times in aeronautics, where you're talking about pilots operating aircraft. There's certain times in a variety of other high-risk situations that are just not amenable to having a checklist. And you just got to need to know what to do and respond immediately. And that is part of what ERADs are about. Another thing, what ERADs or emergency reflex action drills are not. They are not mnemonics to think about or troubleshoot different things. So a classic would be DOPE. So if you're having a problem with a patient who's mechanically ventilated and the peak pressures are going off and they're alarming and the patient's hypoxic, the classic teaching for troubleshooting problems is DOPEs. Displacement of the tube, obstruction of the tube or the airways, pneumothorax, the equipment, etc., etc., etc. Right? This mnemonic is designed to help you think through the major troubleshooting pieces in this particular situation. And that's great. That is helpful in certain situations. But if we were to turn this into an emergency reflex action drill, it would look something like immediately disconnect the patient from the vent and put them on a bag. Suction the tube empirically to make sure there's nothing obstructing it, there's no mucus plugs or anything like that. Check the mouth for displacement of the tube, and then grab an ultrasound and throw it on the chest to look at or look for pneumothoraces. That would be the equivalent emergency reflex action drill for troubleshooting problems with a patient on the vent. So it's not a mnemonic to think about things, it's a behavioral pattern to execute. So what I'm going to go through now is how would you actually build an emergency reflex action drill? So I'm going through this 3 steps that you can either build your own emergency reflex action drill or help others in terms of training them to build theirs. So step 1, you have to think of a time-sensitive problem, and it's generally more helpful if it's something that's common. So, for example, going back to what I said I was going to talk about, which was airway management, very common problem. I wish, even after years of being a paramedic and now an emergency medicine resident, that every single time I stuck a laryngoscope in someone's mouth, it looked like this. And I had this beautiful view of the cords, and getting the tube in was no problem. Well, often, still, even after proper positioning and setting everything up and ensuring optimal physiology, etc., I see this. You get a grade 3 or a grade 4 view that is certainly suboptimal. So this is a very common problem, difficulty obtaining a view for intubation. And again, it's something that's time sensitive. We don't actually stop when we get this grade 3 view and pull out a checklist, the I can't see crap in the mouth checklist, and go through it to try and figure things out. And in many situations with patients that are critically ill, you don't have a lot of time to sit there and have a conversation or discuss troubleshooting with people. You have to act fairly quickly and decisively. And so I would say that's step one: identify the situation. Step two is then you design an evidence-based emergency reflex action drill. So this is where you actually go back to the literature and you say, okay, in these situations, given these constraints, in this environment, whether it's the OR or pre-hospital or the emergency department, what evidence exists that would help me build a set of skills that are at least grounded in some pretty good science? And for this common airway problem that I run into, I refer to a series of skills that I use to build this emergency reflex action drill that were developed by a friend of mine, a very experienced airway guru from Dalhousie University in Halifax named George Kovacs. And his 3 steps are the following: occipital lift, external laryngeal manipulation, and grabbing the bougie. So here's George demonstrating some of those skills. So the very first thing he does is, even with optimal positioning, the hand that he's not using to do laryngoscopy actually gets under the occiput and lifts the head directly up. And there's some good evidence for this, because we know that depending upon the position of the head determines the how the different planes of the airway, the oropharynx and the glottic opening and the trachea, all kind of line up together. And we know that by lifting the head and getting them in a very good sniffing position actually gives us the best angle between those planes. So here we can see that of these different angles, the angle is lowest here in between the posterior oropharynx and the glottic opening in the trachea. So it's kind of very helpful. Likewise, there's been some evidence published by our friend Rich Levitan and other authors that shows that actually the percentage of glottic opening, or POGO score, increases significantly when you elevate the head. So if they're head flat, you can generally see in this study approximately 30%, 35% plus or minus percent glottic opening, and that increases significantly to more than 80 to 85% when you just lift the head. So it can be very helpful to optimize your view of the glottis. Number 2, external laryngeal manipulation. And what George is talking about in this circumstance is basically the intubator, the person who's instrumenting the airway, put their fingers directly on the larynx and manipulate to give themselves the best view. The assistant would then take over holding that position of the glottis so that you maintain that very good view of the glottic structures and glottic opening. And what we can see in various studies that have showed us is that, again, looking at the percentage of glottic opening, it increases significantly. So here, this is just with the person instrumenting the airway looking with the laryngoscope with no manipulation of the glottic structures. Here is the handy assistant actually doing the classic cricoid pressure or burp, which doesn't significantly increase the percent of glottic opening and help your view. But when you have either the laryngoscopist, him or herself, or an assistant with guidance from the laryngoscopist moving and performing the external laryngeal manipulation, we see that the percent glottic opening increases significantly. So that can be pretty helpful. And step 3 is grabbing the bougie. And recently there have been some very nice articles that demonstrate that first pass success actually can improve by using the bougie first instead of relegating it to a backup tool, or a tool that's only used if you fail on the first attempt. So that is the evidence behind those 3 steps. Now, the third step is possibly the most important, because it's one thing to say, this is what I'm going to do in these circumstances, and this is what the evidence says might be helpful, but it's another thing to actually execute it when you're stressed out. So step 3, you have to train your brain to do this stuff in stressful situations. Now, We very commonly say, hey, practice makes perfect, but that's not necessarily it. It's not just doing something over and over again and practicing it, but it's how you practice that really counts. And we know this from evidence in the world of psychology and cognitive science that has looked at how people become true experts. And in particular, the work of Anders Ericsson has demonstrated that is not just practice makes perfect, it's deliberate practice that makes perfect. So how do we practice deliberately and actually imprint these emergency reflex action drills in our brain? Well, it starts out with targeted practice. You have to have specific goals or targets that you're working to. So for example, with my 3-step drill, I want to be able to respond 100% of the time in 5 seconds or less when I see a grade 3 or grade 4 view of the vocal cords with this specific sequence all the time, every single time. So I want to be able to do it quickly and immediately after seeing the stimulus, which is the poor view, and I want to be able to do it in less than 5 seconds. Your practice has to be focused. So what I mean by focused is there's no distractions or idle chat. You're not just going in and playing with a mannequin head and practicing and sticking the tube in. You're actually 100% focused on every single step of that exercise. Intention is very, very important when you're trying to master skills. So there's no music in the background. You're not being distracted by your friends or other people. You're thinking about each and every step, exactly how you're moving the hand to get it under the occiput and how you're lifting. The next step, how you're reaching around and manipulating the larynx. The final step, where you put the bougie next to you and exactly how you're going to pick it up. All of these things are very important. Next part of deliberate practice is actually getting some quantitative feedback. How long did it take me to do things? So timing things to know exactly how many seconds or hundreds or tenths of a second it took you to execute a particular skill. Did I actually do it correctly? In certain instances, this is a little bit easier than others. For example, did I do it correctly might be, did I get the endotracheal tube into the trachea? And if you're using a mannequin or if you're using a cadaver or even on real patients, this especially in practice when you're not doing it on real patients, can be pretty straightforward because you can actually look and see that you're in the right place. How many movements did it take me? All of these things looking at quantitative feedback. And this can be done quite simply. I've seen people take an iPad or an iPhone and just videotape themselves performing some of these skills and practicing some of these reaction drills. And that gives you time. You can see exactly what you did, how efficient your movements are, etc., etc. Another part of it is actually getting qualitative feedback. So it's very helpful to have a friend, or in particular an expert in the field, someone who's very skilled and has done this very often, to give you feedback and say, hey, actually, I noticed that where you put the bougie, it was kind of far behind you, and you had to take your eyes off that view of the glottic opening to reach over and grab the bougie. So maybe putting it right in front of you or right next to the patient, or having someone hold it and just hand it to you would be better. Having that kind of feedback to help you and give you tips along the way is key to deliberate practice. Another thing is you have to be able to push yourself outside of your comfort zone. So some people have been doing this for many, many years, and they have various degrees of expertise, and you get comfortable with kind of the way you do things. Well, that may not be the best or most efficient way. And even as you're training, if you're looking to get better, we should be constantly pushing ourselves to do it more quickly, more efficiently, and that may be setting quicker time goals for yourself. It may be limiting the amount of steps or individual movements that you take to execute a particular ERAD. It may be whatever, but the idea is to continually push yourself outside of your comfort zone so that you're actually growing. And the final thing is developing mental representation. So we know that whether you're a golf pro or a chess master or a special operations operator, that what people who are truly expert have, that one of the things that differentiates them from novices is that they have very nuanced, very detailed mental representations of their brain of how certain skills are done or how certain situations appear to them. And in reviews or interviews, actually, with chess masters, what they will tell you is they will describe their next moves on the board. They will actually be able to think steps ahead and see the game on the chessboard evolving before it actually happens. Pilots actually have very nuanced mental representations of different maneuvers for an aircraft, whether it's takeoff, landing, or various aerobatics for that matter. They have very definitive mental representations. What does this mean for developing our ERADs? Well, as you're going through with this focused, very specific practice with quantitative and qualitative feedback, you're actually refining that mental representation. It's getting stronger and stronger, and we can actually make it even stronger still by accessing those mental representations and undergoing mental practice. So before you have to use some of these ERADs in real life, whether it's an airway skill like the one I was just talking about, or whether it's a trauma resuscitation skill like putting in a chest tube or a central line, or you name it, you can actually practice them in your head. So as you're getting ready to perform a certain skill and setting up your equipment, you're actually running through that emergency reflex action drill in your head just in case you need to do it. So that mental practice can be helpful as well. Finally, you have to do it over and over again. So this is the repetition part of things. And the question always comes up, well, how many times do you have to do something before it becomes an ingrained habit? And the answer is we're not exactly sure, and it varies from task to task. For example, when psychologists look at training people to do simple behavioral things like getting them to drink a glass of water every night with dinner to improve their health. Well, apparently it takes somewhere between 60 and 68 days to get them to do it quite regularly. More complex skills can take longer, somewhere on the order of 100 to 200 repetitions or days of practice before they actually become ingrained or automatic. Now, this is a big jump, but we can look at the literature regarding intubation to say, well, on average, how many procedures or how many intubations do you need to do before your rate of success, or first pass success in particular, reaches about 90%. And again, this is extrapolation from the data that exists and some of the studies that have been done, but it's the best we have, and it's the best answer I can provide people. Is it looks like somewhere in the order of 75, 79 plus or minus intubations before people reach that level. So I might guess, my hypothesis would be, it takes somewhere between 70 to 90 repetitions of this emergency reflex action drill before it more or less becomes automatic. Now, what I've just suggested or the ERADs that I have just suggested has very specific limitations, and those limitations are generally quite clear in that I have not studied ERADs to demonstrate that executing or training these reflex action drills actually improves outcomes in any way, shape, or form, or avoids errors or increases safety or anything like that. I haven't tested it yet. I hope to in the near future. I think that the evidence from other high-risk occupations is promising, but I can't tell you that this is actually going to improve outcomes quite yet. So we talked about the effects of stress on cognitions, and then I gave you some examples, human factors examples from other domains of how we've solved these problems. And finally, I talked about a specific emergency reflex action drill and building fixed motor responses, and gave you the example of that airway drill developed by my friend George Kovacs. I think what it comes down to is this. We have some very good evidence about various skills or various medical interventions in emergencies, and people have very strong feelings about some of these things. However, if we maintain our sort of ivory tower expectations for how we're actually going to execute these skills, the transition from advanced trauma life support or pre-hospital trauma life support or name your skill or training experience to real life at the side of the bed or on the side of the road at 2 a.m. will never, ever be what the standard is or what it's like to practice in a classroom until we recognize that the way our brains work and the way humans behave in these stressful situations is fundamentally different. And until we adapt the evidence appropriately for how we can intervene and how we can execute some of these medical skills in stressful situations, I have the feeling that we will continually fall short of our performance expectations in these situations. And I think that emergency reflex action drills are one way to move toward improving our performance. So thank you guys very much for your time. I sincerely appreciate you listening to this video. If you have any questions or comments, please let me know. If you take a look at this QR code or type in this URL address, tinyurl.com/ERADs, it will take you to a list of 30 references that I used to build this presentation. Feel free to follow me on Twitter. I'm at RecessPadawan. Or if you have any questions, shoot me an email at mjloria@salud.unm.edu. Thank you guys very much. Take care. Bye-bye.